We know that for patients with stable CAD, sometimes optimal medical therapy is just as good as PCI. So what we want to do today is talk about achieving optimal medical therapy. It's one thing in a clinical trial, how well are we actually doing it in a day-to-day clinical practice? In the April 29th issue of JACC, a paper gets us a little closer to answering that question. The paper is Achievement of Optimal Medical Therapy Goals for U.S. Adults with Coronary Artery Disease and its Results from the REGARDS Study. My regards to Dr. Vera Bittner, who is MD, Professor of Medicine and Section Head of Preventive Cardiology and Medical Director of the CCU and Cardiac Rehab Program at the University of Alabama at Birmingham. We probably should note first that the first author of this paper is Todd M. Brown, who's also an MD, and he did a great job on this paper for JACC.
Yeah, I mean, Todd unfortunately couldn't attend the meeting, and so I kind of agreed to fill in for him for this interview.
Well, also my regards to this study, because this is an important topic, and let's talk a little bit about the trial and what we're learning about just how well or how poorly we're doing with optimal medical therapy.
Yeah, so REGARDS is not a trial. I mean, REGARDS is an observational study. It's a very large cohort of individuals recruited from the stroke belt and buckle, about half the population, and the rest of the population from the remainder of the United States, trying to look at stroke risk factors. So that's the original purpose of this study. And the vast majority of these people did not have any pre-existing coronary disease, but about 3,000 individuals did. And so Todd asked the simple question, if we look at this cohort of community-dwelling adults, how many actually meet these optimal medical therapy goals that had been defined for the COURAGE study?
And what did he find?
Well, he basically found, kind of what we expected is that only a minority of individuals actually meets these goals. One important caveat, obviously, is this is not a quality of care analysis. That is basically a snapshot of what is going on in the community, and the vast majority of individuals were recruited before the COURAGE paper was actually published, and some of the guidelines in effect at that time didn't have quite as aggressive a risk factor goal as what they had set themselves in the COURAGE trial. But nevertheless, what he found is that out of the goals of aspirin therapy, blood pressure control, lipid control, BMI, physical activity, etc. The 7 goals that the COURAGE investigators set, the median achievement in the general population was only 4, and when you looked at all of these goals, less than 1% met all of these goals. Suggesting that if we actually implemented this strategy and got everybody to goal, we could have a huge impact on subsequent outcomes.
And these are obviously high-risk patients. They do live in what's called the stroke belt, and by definition, these are people who actually need some real good preventive care.
Well, these were individuals already with coronary disease, specifically, and so by definition, they were higher risk individuals.
So in terms of any recommendations?
Well, the question is, we know what we need to do. And we know that in a clinical trial setting, it can be achieved at least in a proportion of the population. The question is how easily translatable that will be to day-to-day practice. And I think it drives home the point that we have an opportunity to make a big difference, but we also have to invest the resources to accomplish that.
I was at a meeting recently, and they were talking about a patient who she kept returning time and time again with heart failure to the hospital until somebody visited her home, and they found that she had literally a candy bowl that she poured all of her meds into, and every morning she walked by and she picked up a handful, and that's what she took during the day. So it's really difficult to get patients to adhere to medication when they clearly do not understand some of the basics of what they need to do in order to help themselves.
Clearly, and that's why I think there's now an increased emphasis on patient education, both at the time, when the person transitions from hospital to home, because that tends to be a very confusing, part of their life. They're overwhelmed by the diagnosis. Everything is very hectic, and they may not even understand what medications to take or, how to take them, what kind of lifestyles to adopt. And so that's, I think, one of the reasons, in this hospital-to-home transition where cardiac rehabilitation can then make a huge difference, because that's where, trained professionals can take the time to have education sessions about lifestyle, teach people how to exercise, have the dietitian involved, emphasize adherence to medications and so on and so forth. So I think that is a big area, at least in newly diagnosed coronary disease patients who just came out of the hospital with an event, and as well in the stable angina population where involvement in cardiac rehab could make a big difference.
Well, Dr. Bittner's colleague, Todd Brown, is the one who is the first author of this paper, and it is coming up in the April 29th issue of JACC. Please take a look at it. It is a great snapshot of just how well we're doing with day-to-day clinical practice and specifically patients and how well they're doing with optimal medical therapy. For CardioSource World News, I'm Rick McGuire.